Friends, welcome to the 36th online meeting of our foundation. Did you know mosquitoes evolved more than 100 million years ago? Among over 1,000 types of mosquitoes that exist today, only 3 genera transmit human disease: the Anopheles, Cutex, and Aedes mosquitoes. And only the female mosquitoes bite since they need the blood to produce their eggs. The male mosquitoes are very gentle, happy, and they survive just on nectar alone. They do not bite. Mosquitoes have killed with unremitting potency and dictated the course of history. They have shaped the outcome of wars in Europe. They have influenced the rise and fall of the Roman Empire. And it is said that failure of the Christians to capture the Holy Land during the Crusade War was partly because the plasmodium-infected mosquitoes attacked inexperienced crusaders. Mosquito-borne diseases today infect up to 700 million people and kill more than 1 million every year. We are told that as the planet warms and the climate change lengthens the mosquito season, the world's deadliest creature will expand its geographical range to new regions. The early warning system for mosquito-borne disease shows an upward trajectory in Europe, with cases of malaria increasing by 62% and dengue, Zika, and chikungunya by 700%. Southern Australia is another example of mosquitoes expanding to new regions. 2 years ago, the region was struggling with its first major outbreak of Japanese encephalitis, a mosquito-transmitted infection more commonly found in Southeast Asia and the Pacific Islands. Extreme flooding in Germany recently saw the mosquito numbers increasing by 10 times their usual numbers there. There is now continuous research on the spread of mosquito-borne diseases and the measures that must be adopted for controlling their numbers. Today, Dr. Sindur Nambi will tell us a little bit about the disease caused by these little monsters, how to recognize them, how to recognize the symptoms and treat the condition. I do not have to introduce Dr. Nambi, as most of you know who he is, as he had already spoken to us recently on a different topic. He graduated from Stanley Medical College and did his MT General Medicine from Kilpauk Medical College. He's a fellow of the National Board in Infectious Diseases and certified by the Royal College of Physicians in Infectious Disease. He's a governing council member of Clinical Infectious Diseases Society in India and senior consultant in infectious diseases at Apollo Group of Hospitals in Chennai. Without wasting any more time, let me ask Dr. Nambi to take over and address our group. Over to you, Dr. Nambi.
Good evening, Dr. Badrinath. I'll just start sharing my slides. Thank you, Dr. Badrinath, for having me to speak on mosquito-borne diseases. I think he was an orthopedician, but the way he kind of elucidated everything about mosquitoes, it actually made my job a little easier. And then when he was speaking about the male versus female mosquito, I could see that Mrs. Badrinath is also in the meeting thing, and perhaps he will have something to care about tonight when he kind of spends time with her. And it's a kind of a fascinating vector. And as he already pointed out, the basic nature for all the living beings is propagation, and then basic survival is hunger. And for the females to kind of produce, they need to feed on blood, and it could be blood of humans like us, or it could be some other animals for them to survive. And that's how it is. And with respect to mosquito-borne diseases, and this is the actual global air travel map, and that's the number of flights on a daily basis. So that's a problem in this day and age. It was not like this many years ago, and now that's the number of flights. US, Europe, Middle East Asia, and Southeast Asia, they have the busiest air routes, the number of flights on a daily basis. This is actually the international travel map. So what happens in Africa could be easily transported to India. If there is monkeypox in Africa, then in a probably in 2 3 months you'll get monkeypox in America and monkeypox in India. And whenever there is air travel, humans carry the virus, bacteria along with them. At times, vectors also sneak in through those air travel, and that's a problem. And the world is not the same anymore. And we all knew with COVID what happened in one corner of the world, like the big C, China. It quickly spread to the entire world, and still we are talking about the big C, COVID, with respect to the vaccines, all those things. And if you cut off travel, you're not going to have these infections spread from one place to other. Unfortunately, it doesn't work out that way. When Australia and New Zealand, when the COVID pandemic came up, they had a slightly different approach, and they kind of have had a total travel ban, both Australia and New Zealand, because they are natural islands. They could do that, but they could hold on for a year or two. And once the travel scene opened up, COVID came into Australia, COVID came into New Zealand, and that's not practically possible to cut off travel. This is with respect to the major mosquito-borne diseases. The top four things would be dengue, malaria, then you have Japanese encephalitis and chikungunya. And this is over the years from 1970s to 2020. Perhaps when you all graduated, the major vector-borne disease was malaria, and probably you would have not had that much of dengue. But now, if you see over the years, especially from the year 2000 to 2022, now in the last 2 decades, it's not no longer malaria, the commonest mosquito-borne disease in India. It is actually the dengue. The malaria is actually the blue graph. Dengue is actually the red graph. Japanese encephalitis is actually the green one. What is the current problem in India is Anopheles, which was the vector for malaria, has been replaced by Aedes mosquito. And Aedes is the chief transmitter of dengue. So we find dengue much more common nowadays all over India and all over Asia when compared to malaria. But that's not the case in Africa. In Africa, still malaria is much more commoner than dengue. But the South Americas, Asias, India, they all have dengue. Dengue is far more common than malaria and other mosquito-borne diseases in South America and Asia. With respect to the impact on mortality, malaria, dengue, both are actually deadly diseases with respect to their killing power. And in the deaths due to malaria, as it was already I had mentioned, from the year 2000, the malaria, the incidence has come down. As a result, the malaria deaths also come down. Dengue was not there in India or the Asian subcontinent prior to the 1990s. So it came late in the 1994-95. You had the first big epidemic of dengue in Delhi. And after that, dengue has become the number one cause for mosquito-driven deaths in India. And of course, you do get Japanese encephalitis, but Japanese encephalitis is not something that you would find all over India. It is in selected areas. But dengue as a disease, you see it all over India. And that's the current status, what we have in India. What we need to understand is with respect to all these vector-driven diseases, let it be malaria, dengue, or other tropical infections like enteric fever, leptospirosis, crop typhus, they all present as an undifferentiated fever syndrome. So what do I mean by an undifferentiated fever syndrome is people have fever, headache, myalgia, arthralgia. At times they have cough, abdominal pain. So their clinical history or examination is not localized to one particular system. So that is what we call as an undifferentiated fever. They have protein manifestations starting from headache, body pain, joint pains, abdominal pain, cough, arthralgias. And when you have these undifferentiated fever syndromes in India, or someone who has traveled to India or Asia comes back to the US, UK with these kind of symptoms, then you're looking at tropical infections, typically vector-borne diseases. The clinical examination, you would always look at for rash, a scar, hepatosplenomegaly, purpura, something like that. The basic labs in that situation would be do a complete hemogram, liver function test. The dengue would do a dengue NS1 antigen. The NS1 antigen is called the non-structural 1 antigen. Then for malaria, I would do the malarial smears. And fever more than 3 days, you have to rule out enteric fever in Asia and South America. You'll have to do blood cultures. Serologies like antibodies, IgM antibodies for scrub typhus, leptospirosis, or dengue. Generally, you don't do it in the initial 5 days of illness. So the basic principle for all these infection is the initial 5 days, you try to detect the virus in the body or look for antigens. And once you cross day 4, day 5, you look for the presence of antibodies, the IgM antibodies. That is what you would do. The complete hemogram is the gateway for all these vector-borne diseases or tropical infections. And they fall into this syndrome of undifferentiated fever syndromes, where you're not able to localize the symptoms to one particular organ involvement. This is the global dengue map. And if you see India in the big red zone there, so India has got the most highest burden of dengue in the whole world, followed by other Southeast Asian countries and Brazil. And Americas and Europe and Africa's, China are kind of relatively spat. Southern China has got a lot of dengue, but India has got the highest burden of dengue in the whole world. And that's the map, the India map on dengue. This is taken from the Indian government website. If you could see that the whole of India is bleeding red. The whole of India is bleeding red, except for some portions in Jammu and Kashmir. Probably Leh and Ladakh is one area where you don't get dengue because you don't get Aedes mosquito in very, very high altitude. Otherwise, entire India, if there is one mosquito-borne disease, it is actually dengue. It is actually dengue. And then it's there all throughout the years. But if you see in the graph that is placed parallel to the India map, you would see that dengue generally follows the monsoons. So it follows the rains. Rains leads to the accumulation of water, and accumulation of water leads to breeding of the mosquitoes, the Aedes mosquito. So the dengue peak happens from August, September, October, November, December, the later half of the year. So if you look into the country as a whole, 30% of the dengue cases happen from January to June. From July to December, the remaining 70 to 80% of the dengue cases happen. It is there all throughout the year, but it is much, much more commoner during the rain season because rains leads to the temporary accumulation of all these rainwater. Aedes breeds in clean water. So whenever there is rain, there is clean water accumulation that leads to Aedes, and then Aedes leads on to dengue. And wherever there is urbanization, there is construction. Whenever there is construction, there is always water storage. And our cities are expanding. As a result, if you have expansion, urbanization, construction activity, rains, that leads to dengue. And that's why it is the commonest problem in all these developing nations, let it be Brazil, southern part of China, India, something like that. Dengue virus is a fascinating virus. It was not a problem prior to the 1990s. We need to remember that. It belongs to the flavivirus family. It's an RNA virus. There are 4 types of dengue virus, dengue 1, 2, 3, 4. And if you get dengue 1 virus once, when you get bitten by a mosquito having dengue 1 virus another time, you're protected. The problem with dengue is if you get bitten by a mosquito with dengue 1 virus, and then you get bitten by a mosquito sometime later, a year later, and that kind of transmits your dengue 2 serotype virus into you, it can always have much more catastrophic effects. So the primary dengue, so all of us can have dengue 4 times in our lifetime because there are 4 different types of virus. The first attack of dengue generally doesn't have much of a problems, whereas the second or the third attack can have problems because your immune system is already sensitized to the virus. And when another serotype comes, the immune system overreacts. That is cytokine storm, inflammatory cascade. So the problem with dengue is not with the first infection or the primary infection. It is always with the second infection or the third infection. You need to keep that in mind because the immune system acts as a foe with dengue secondary infection. The vector is Aedes albopictus and Aedes aegypti, which we commonly call as the tiger mosquito, where we have this stripes of white stripes in the mosquito and breeds in clean water. It's a daytime feeder. It does not bite in the nights, and it does not cause that much of itching, or you don't feel the bite. So the bite is always imperceptible, and it needs to bite multiple people to have one good blood meal. So that's the problem with dengue. And so if you're going to have friends to your home and spending 2 hours, and then all you have is one Aedes mosquito, and if it is going to kind of bite all of them and then have one meal, and then that's good enough for them to pick up dengue virus, because it does not get satisfied with 1 or 2 bites. So it needs around 6 to 8 people for them to have one good satisfactory blood meal. And that's a problem with dengue. And that's the reason why it can go into epidemics. The fever is a sudden onset of fever with headache, muscle pain, joint pain, nausea, and vomiting. The rash generally you see by the day 4, day 5. And this is a kind of a typical dengue rash, or what you called as you got isles of white in the sea of red. And I'm not sure if you're able to appreciate that. You got a sea of red, and in which you could find some isles of white. And that's a classic dengue rash, and you don't find this pattern in other kind of infections. You have a reddish background, and that you would have some whitish spots. And when you're going to touch these people, these kind of rashes generally blanches actually, and that actually reflects the capillary fragility. And this kind of rash is little uncommon in the primary dengue. That's the first episode of dengue. But if you're going to have a secondary dengue, that is when your immune system acts as a foe. As a result, the blood vessels start leaking, and there is extravasation, there is organ dysfunction, and so much of other complications can happen. How do I diagnose dengue? Of course, the history: fever, headache, body pain, joint pain. But you need to demonstrate the virus in the initial 5 days of illness. You could either do a non-structural one antigen ELISA, the NS1 antigen, or you try isolating the virus. The virus cultures, all those things are of theoretical interest. So what do you do in general is do an NS1 antigen, or if you have access to a PCR, you pick up the virus in the initial 5 days. Once you cross 5 days, then you look for the presence of the antibody, the IgM antibody. When you have that, then you have the diagnosis of dengue. It's a kind of a fascinating disease. I would always call it as a 10 to 14-day disease. The initial 3 days, the febrile phase, where the fever is high grade, kind of zaps you down with severe headache, body pain, temperatures going up to 102, 103. The focus is control of fever and hydration. The initial 3, 4 days, your hematocrit, platelets, all seems to be normal. All you have is the virus dancing in your blood in the initial 3, 4 days. The problem happens in dengue when the fever settles. When the fever settles, when the viremia settles, the fever settles. What does that mean is when the viremia settles, your body has started producing antibodies. Unfortunately, the antibodies that are supposed to protect your body now goes on to attack your blood vessels, your organs, and it can start to consume your platelets. So this is the critical period, especially when that secondary period of dengue, secondary dengue, between day 4 to day 7, where the hematocrit increases, your PCV, hemoglobin increases, your platelet drops. Many a times people do miss this window period, where when the fever settles, everyone thinks that, okay, we have conquered the disease. But the problem happens in dengue when the fever settles between day 4 to day 7. The key here is to get the vital signs checked, measure the urine output, blood pressure, focus on hydration, IV plus oral. Once you cross the day 6, day 7, if you manage your hydration well, your organ perfusion well, generally the critical phase does not go on to end organ dysfunction. And then by day 6, day 7, your body begins to recover. That time, what you do is you don't hydrate at that time with intravenous. you have to give oral hydration. Because if you keep on pumping IV fluids at that point of time, what happens is there will be fluid overload, because already the blood vessels are leaky, and then there is extravasation of fluid. There is fluid accumulation in the pleural spaces, in the peritoneal space, and there is edema. There is, once you reach the recovery phase, you don't give IV fluids. By day 7, day 8, you encourage oral fluids. So the hydration, oral plus IV between day 4 to day 7 is the key. The history is very, very important to check when was the fever was starting. So this is how the dengue presents, and unfortunately, we don't have any antivirals. The key here is to get the history, get the diagnosis, focus on hydration, control of fever with paracetamol. Treatment, no specific antivirals all over the world. In general, with dengue, you would avoid aspirin and NSAIDs, non-steroidal anti-inflammatories, because it could provoke bleeding. As a result, you avoid NSAIDs for fever control. All you have to do is paracetamol, tepid sponging. The best fluid to be given is normal saline or ringer lactate. All other fluids are not required. In general, you don't do blood transfusions. You do it only when the patient has bleeding. Otherwise, just focus on hydration, oral plus or minus IV. And there is a tendency to give prophylactic blood transfusions, because with dengue, there is drop in platelets. The normal platelet value is around 1.5 to 1.2 to 1.5 to 2.5 lakhs. But when you go through that critical phase, especially in that secondary dengue, it can drop up to 5,000, 7,000, 10,000 to that levels. So there is always worry, is there going to be a bleed, all those things. But there is enough number of studies to say that in general, you don't need to prophylactically give platelets, because platelets are short-lived. They live in the system only for 4 to 6 hours. And again, with dengue, you have antibodies against the platelets. So even if you're going to give platelets, it's going to get knocked off. So there's no point giving platelets prophylactically. In general, what we do is we give platelets when the platelet drops to less than 10,000, or when there is bleeding. Otherwise, avoid trauma, minimize trauma, focus on hydration, oral IV, and in general, not do much. Just wait and watch. Careful monitoring of the vital signs. Look at the blood pressure. Look at the pulse rate. Look at the urine output. That is much, much more important in that things. Since it is an immune-mediated phenomenon where your immune system is acting as a foe, is there a role for steroids? There are uh, many investigators, especially from Asia, Sri Lanka, Malaysia, they tried checking into steroids. Can this help in preventing the inflammatory cascade, cytokine storm? But in general, it's quite clear that even though it is experimental, whatever data that we have, steroids are not going to be useful. At times, it can harm, it can kind of invoke bleed, all those things. So it's not a good idea to think about steroids when your patient with dengue goes in for hemorrhagic manifestations. So going on to the other disease, malaria, I think this is something which should have been taught to you when you were in the medical schools. Malaria, malaria, malaria. I think those days, the focus was on giving empiric antimalarials. So someone had fever, rigor, chills, has a splenomegaly, then you have malaria, then give chloroquine. So that was the thought process. But now the thought process is completely different, because if you look into it, the dengue map was India was bleeding red, whereas in the malaria map, the red zones are predominantly you would see in northeast India, Odisha, Chhattisgarh, Odisha, Jharkhand, Chhattisgarh. Otherwise, most of the other states have a reasonable control or reasonable hold on the malaria cases. So empiric antimalarials are no longer recommended for all our fever patients. So the current government policy, the National Malaria Eradication Program, clearly states that you need to confirm malaria by parasitologic diagnosis. You need to diagnose malaria, then give antimalarials, not to give empiric antimalarials. That is the current practice, current recommendation. So how do I diagnose malaria? A good old smear study. You could either do a thick film where you have multiple sheets of RBCs. That is good enough to pick up if there is a parasite sitting in there. So the thick film is for picking up the parasite, whereas the thin film is just where you have one sheet of RBC there. So that helps in looking into the characteristic of the parasite. So it would help in identification of the species, whereas thick film is a checking if there is a parasite is there or not. So you need to do a thick film or a thin film. Unfortunately for this, you need to have a good microscopist. It needs a proper technique to prepare smears. The person has to be good. He needs to be experienced. Going on to the other big mosquito-borne disease, chikungunya. And chikungunya is actually a re-emerging disease, fever with debilitating arthralgia. And the word chikungunya actually comes from the African word kungun yala. What does that mean is which bends up or gets folded. Someone has chikungunya, he's not able to walk straight. He walks in a stoop posture. So it bends you up or makes you get folded. And that's how the name chikungunya came, kungunyala. So from that, it came kungunya, chikungunya. The vector is Aedes, just like dengue, and it can come through mosquito bite, is the commonest thing. From all these vector-borne diseases, it can be maternal to fetal transmission, blood transfusion, all those things. And they have a human cycle, the urban transmission cycle, and then you have the forest cycle. Both the things are also there. The African forest, the forest cycle, which is known as the sylvian transmission cycle, that is responsible for circulation in the forest area. Whereas what bothers us is the urban transmission cycle. Chikungunya virus classically has got three genotypes, the West African, East African, and the Asian genotypes. Until 1973 in India, we had only Asian genotypes. It was not a problem until 2005, when you had this famous Reunion Island outbreak in 2005. In the Reunion Island outbreak, 2/3 of the population was infected with chikungunya, and 1/3 had the disease with debilitating effects with severe arthralgia for years to recover. So what was unique about this reunion outbreak is you got a new vector. Earlier, it was only Aedes aegypti. But with this, since the year 2005, in addition to Aedes aegypti, you have Aedes albopictus as a cause, as a vector driving chikungunya all over the world. And that is because you got a new mutation in the virus. So the virus has mutated. The mutated virus has picked up a new vector, of course, belonging to the Aedes family. So it is in a much more virulent form. And how does chikungunya presents? Very short incubation period of 3 to 7 days, just like dengue. As a result, it has got a huge epidemic potential, abrupt onset of fever with severe joint pain, arthritis. The arthritis is polyarticular, multiple joints. It's migratory, looking like acute rheumatic fever. Now you don't see rheumatic fever any longer in India, but it has a migratory arthritis. And the ankle is predominantly like a swelling of the ankle. When you see that, you think, okay, my patient has got a renal failure, nephrotic syndrome, something like that. But they have a fever, joint pain. They come with edematous, swollen legs. It is a polyarthritis. The other symptoms would be headache, muscle pain, tenosynovitis, skin rashes, etc. Most people recover within a week, but some, the joint pain goes on for n number of weeks up to years. The higher risk groups would be the extremes of age like newborns, older adults, and someone with underlying comorbidities. As with dengue, for chikungunya, you don't have any antiviral treatment. In a country like India, where the vector is the same for both chikungunya and dengue, for a clinician like me, it becomes difficult. At times, we have to differentiate between either of those because chikungunya is rarely a deadly disease. It is a debilitating disease. Whereas dengue plays the game short, but it can be deadly, especially from day 4 to 7. So we have to differentiate clinically, of course, pending reports. Fever is common in both. Arthritis is uncommon in dengue. Tenosynovitis is uncommon in dengue. In chikungunya, the rashes come much more earlier. With dengue, the rashes comes much more earlier, much more later. The cytopenias are much more commoner in dengue. So these are the kind of symptom analysis that we try to keep to differentiate whether we're dealing with chikungunya or dengue. But of course, there are always outliers. You may have someone with chikungunya with the thrombocytopenia also, someone with dengue with severe arthritis also. But the majority, chikungunya, you don't have low blood counts. And the arthritis is what is striking in chikungunya. and the blood pressure is always normal in patients with chikungunya, and you don't find any of those endothelial dysfunction, capillary fragility in chikungunya patients. The diagnosis, of course, the epidemiology, all those things. As with most of these viruses, the initial 5 days, you try picking up the virus. You either do a viral cultures or a PCR or an antigen. Once you cross day 5, you'll have to look for antibodies, the IgM antibodies. That is what is done. And that's the principle wise remains the same. Let it be chikungunya, dengue, or any virus, Zika virus, Ebola virus. Initial 5 to 7 days, look for the virus, culture, PCR, or some antigen. Once you cross day 5, day 7, look for the antibody, IgM. That's it. Going on to another fascinating disease. This was one disease which kind of dramatic appearance in Brazil, and that's the statistics with respect to number of microcephaly cases in Brazil. From the year 2000 to 2014, it was actually very fine, the normal steady graph. Suddenly in the year 2015, they found a steep increase of microcephaly. So when they were trying to analyze why is this microcephaly happening, they found a new virus called Zika virus. And Zika is another Aedes driven mosquito-borne disease. And it's a kind of a disease which does not affect the individual. So if Zika comes to a man, not a problem. Fever, headache, body pain, 2, 3 days, and then by day 4, day 5, things do get better. Zika comes to women, not a problem. But when the woman is pregnant, the mother does not suffer, but the baby suffers. And it is a kind of a neurotropic virus. So especially in the first trimester, when the organogenesis is there, when the pregnant woman gets Zika, there is a good chance that you could have microcephaly. Just like that, rubella in the first trimester can cause multiple malformations. Zika is one virus. If a pregnant woman picks up, then it could have a lot of neurologic side effects to the baby. And as seen in this Zika, when they had a major epidemic of Zika, the microcephaly cases actually shot up in Brazil. And Zika is a problem in South Americas. We do find Zika in a kind of a sporadic occurrence in India and other countries of Asia. And it is a problem in pregnant women because it is very important to recognize when a pregnant woman presents with fever, with an appropriate history, epidemiology, we may have to keep Zika in mind so that trying to take care of the fetus. Arbovirus encephalitis in India. Arbo is arthropod-borne virus encephalitis. Arthropod-borne. So that is why it is called as arbovirus encephalitis. Predominantly, it is mosquito-driven, in which you have the flavivirus family. The typical encephalitis virus is Japanese encephalitis. Then you have the West Nile virus, something typically that you would see in the US, West Nile virus. In India and other Asian countries, the flavivirus causes encephalitis is Japanese encephalitis. Dengue also belongs to flavivirus family, and dengue can also cause encephalitis. And then Rhabdoviridae family, the commonest one is rabies virus, but rabies virus is not arthropod-borne virus. You have another virus called Chandipura virus that you find predominantly in tribal population in central parts of India. And then you have the Toga virus, in which you got chikungunya. So all these 5 viruses can cause encephalitis. The proper encephalitis or neurotropic viruses are Japanese encephalitis, West Nile virus, and Chandipura, whereas dengue and chikungunya are viruses which do not commonly affect the brain. But when you have an epidemic happening, it's not uncommon to find dengue virus with meningitis, dengue virus with encephalitis, chikungunya with encephalitis, all those things. So that can happen. Japanese encephalitis, and that's the India map for Japanese encephalitis. And the vector here is Culex species of mosquito. The entire South India is actually risk prone for Japanese encephalitis. And you need this combination where you have pigs as the amplifier host. You need to have paddy cultivation. You need to have paddy cultivation, water staying over there, mosquito kind of breeding over that, and then you got small aquatic birds, and then pigs as amplifier host. And when you have this combination happening, paddy fields, and paddy farming is common in South India, common in Southeast Asia. So paddy fields, birds, Culex mosquito, pig farming, swine population, that is a cocktail that you have for Japanese encephalitis. And Japanese encephalitis, as the name suggests, originally came from Japan, but it is there in the entire South Asia as well as India. And in whatever the encephalitis that you see in Uttar Pradesh, where it comes in the news cropping up Gorakhpur encephalitis deaths, it's predominantly Japanese encephalitis. There is no treatment for the virus. All you have to do is supportive care, and it is a debilitating disease. It predominantly affects the children. So children kind of end up having long-term neurologic effects. So that is focus on its prevention, as there is no effective treatment. Treatment is entirely supportive. The prevention is looking at giving vaccines. So there is a vaccine program in this country, in our country. It is not given for all over India. There are Indian government has data regarding what are the states or what are the districts with high prevalence of Japanese encephalitis. In those districts, children are given Japanese encephalitis vaccine. West Nile virus, until 15, 20 years ago, it was a virus in textbooks for Indian clinicians. All we used to think about West Nile virus is it is there in the US. It is there in the US. But we have found this virus causing problems in India too. We have serologic evidence of West Nile virus from Tamil Nadu. There is West Nile virus as a cause for encephalitis in Kerala, Assam, Northeast India. But these are sporadic occurrence, not like Japanese encephalitis, dengue, chikungunya, where you find it all throughout the year. But it is not a disease that is associated only with the Americas. It is there in Asia, provided we do look for. The therapy for West Nile virus is nothing but entirely symptomatic, nothing much we have. Filariasis, probably when you guys graduated, this was again a big topic along with malaria. And the green zones are the areas with the lymphatic filariasis affected. The entire northwest India is filaria free almost, whereas the entire eastern coast, wherever there is coast, wherever there is the sea, let it be the Bay of Bengal, Arabian Sea, you have filariasis. And probably the only exception would be the Uttar Pradesh, Bihar. And you would see it over the coast. That is what you predominantly see for lymphatic filariasis. The vector is Culex, but the parasite is Wuchereria bancrofti. That is responsible for 90% of all the cases. Apart from that, you have other two parasites, Brugia malayi, Brugia timari. But as respect to India, what you see is Wuchereria. The vector could be Culex, could be Anopheles, could be Aedes also. But Culex is the predominant vector. And in addition to that, the rural areas, Anopheles has evolved. In addition to transmitting malaria, it can transmit the filarial parasite too. Aedes in some of the islands in Pacific, Aedes also transmits lymphatic filariasis. Again, this is a kind of a fascinating, difficult disease with respect to the mosquito, which has the larvae, what we call as the L3 larvae. When it kind of bites the human for its blood meal, it injects the larvae into the system. The larvae go on to the lymphatic system and matures into the worms. You have the adult worm, male and the female, which again produce multiple smaller worms, which is known as the microfilaria. And the microfilaria is there in the peripheral circulation. The mosquito comes for a blood meal, picks up the microfilaria in its system, and the microfilaria has its own cycle in the mosquito, where you have again the larval forms L1, L2, L3. The L3 again in the mosquito bites to the human, it transmits the L3. So it's a kind of a complex cycle where the mosquito does not suffer because of the worm, whereas the humans suffer the brunt. And what we see in the blood is microfilaria. What is causing the damage is actually the adult worms residing in the lymphatic system. So as a result, the lower limbs, the scrotal area, at times the upper limbs, breast, all those areas with the natural lymphatic drainage, they are the ones that get affected. So when you try targeting treatment, you may have to give drugs that target the microfilaria, plus give drugs that would target the worms too, because the worms are the one that cause the primary damage to the lymphatic system. How do I diagnose? Good olden days, you do blood film smears. The problem with the smears is this parasite has got a nocturnal periodicity, so you'll have to take smear samples from 11 p.m. to 3 a.m., and that's not practical in most of the situations. But if you want to pick up the microfilaria, that's the time to do the smears, not during the daytime. So there are other newer tests that has been evolved. One is called as the filarial antigen test. So this is again a simple blood test, a card test. So if you have problems in doing microfilaria smear test, which is again labor intensive, where you need to have a good microscopist who can see and then say. But if you can do an immunochromatographic test, filarial antigen test, that is good enough. But that picks up only Wuchereria bankruptcy thing. So you have other one is the anti-filarial antibody test, that in addition to the Wuchereria bankruptcy, it can also pick up Brugia species also. So you have this combination of tests nowadays. It's not the smear anymore. You can do the filarial antigen, what we call as the circulating filarial antigen, CFA. And if you're looking at Brugia species reduction, then you'll have to do antifilarial antibodies. Treatment, the ever favorite DEC, diethylcarmazine. That is something that can affect, that can kill both the microfilaria as well as the adult worms. That is the drug of choice for lymphatic filariasis. And earlier treatment course was for 12 days. Now there is good treatment evidence to say that even a 1-day course may be good enough. You don't need to give a 12-day course. But most clinicians in India would prefer to give a 12-day course, not a 1-day course. The dose would be around 6 milligram per kilogram per day. What is very important is it's very important to catch the disease early in the acute stage. Once it grows to the chronicity, you cannot do much. All you have to do is limit damage control, something like that. Ivermectin is a drug which can be used to kill the microfilaria, no effect on the adult parasite. Ivermectin became famous during COVID time for wrong reasons. It's a drug that would not work, but thanks to COVID anxiety, many drugs were kind of pumped into the use at that time. Albendazole kills adult worms, no action on microfilaria. DEC has effect both on adult worms as well as microfilaria. Ivermectin only against microfilaria, whereas albendazole against adult worms. Now we have kind of go on to an evolution where we at times use the triple therapy. What is this triple therapy? Is we combine DEC along with ivermectin and albendazole. That is called as a triple therapy, where ivermectin targets the microfilaria, albendazole targets the adult worms, whereas the DEC has got both microfilaria as well as the adult worm effect. So this is something that we tend to do nowadays, trying to target the parasite from with different chemicals at different stages. Doxycycline may also be beneficial in the treatment. There are studies highlighting its use. So looking on to prevention, it's a public health disease. So I don't think as an individual we can do much, but whatever we can do from our side, especially for travelers coming into India or other Southeast Asian countries, I would always insist on using mosquito repellent creams, DEET, all these mosquito repellent creams with DEET component, DEET. That is very, very important. Sleep in mosquito nets. In Africa, insecticide treated mosquito nets are quite common there. Long sleeve clothing. So these are personal protective measures that we have to take. Chemoprophylaxis for someone from the US or UK who wants to travel to Africa, then probably I would straight away say do chemoprophylaxis for malaria, because Africa is not a continent to pick up malaria. Falciparum, there is a kind of a deadly form. It's always a problem. The very important thing with all these chemoprophylaxis options, let it be doxycycline, mefloquine, or ataquine proguanil, is it has to be started ahead of the travel, has to be continued during the travel, and then once you come back to your place, probably you may have to take it up to 3 to 4 weeks. But it's worth doing it rather than having complications. So any travel into Africa, you have to consider chemoprophylaxis, especially from the UK, US. Vaccines, there are a lot of vaccines that could be given as a part of the travel vaccines. As such, for prevention, Japanese encephalitis vaccine is a consideration, especially if the traveler is expected to go to rural areas, stay longer there, working in a camp in a rural area for a month or something like that. Then you may have to definitely consider Japanese encephalitis vaccine. For dengue as a disease, vaccine has come, but that is not for the traveler. That is for dengue endemic countries. You got two vaccines. Both the vaccines are World Health Organization approved. One is the dengue vaccine, other one is the Qdenga. This is not for a traveler. This is not for a traveler. This is for the protection of children living in areas with dengue. But the issue with dengue vaccine was it was actually a Sanofi Aventis company vaccine. It had a mandatory screening for pre-vaccination screening. So someone who has had dengue before, you can give the vaccine. Someone has not had a dengue, if you're going to give a dengue vaccine, what happens is your immune system is primed to the virus in smaller quantities. So when you get bitten by a mosquito transmitting dengue virus, if your immune system is already primed because of the vaccine, when you get the actual attack happens, it will create problems. So that was a problem with the dengue vaccine. So this should not be given in people who have not had dengue before. You're going to give that to people who have not had dengue before. The immune system is primed to the vaccine, primed to the dengue virus. So when you get the actual attack, it becomes a catastrophe for the body. So you have to do an antibody testing. The antibody is negative, don't take the vaccine. What's the problem with dengue vaccine? But that has been overcome with this newer vaccine called the Qdenga vaccine or the TAC as 003, which the pre-vaccine screening required. So this is primarily for dengue endemic areas, focusing on children, because children are the age group where dengue has got the highest mortality. So this is looking at that, but this is not for the traveler. And these vaccines, whatever the dengue vaccine development has all happened in the last 5 to 7 years. It is yet to be used in programmatic setup in India so far. So we don't have much of experience with these. All these are literature from the West. I think with that, that is my last slide. I may not have anything more. And I think that's my last slide. I always think that all these mosquito-borne diseases are because of human evolution, the so-called urbanization, development, whatever we have, roads, buildings, and that has led to all the problems. And of course, you add to the travel to that. That's the problem. Thank you.
Thank you, Dr. Nambi. It was a fascinating talk. Had a lot of information, particularly for us who travel a lot. Hearing all the problems that you can face with these mosquitoes, I now start wondering whether we should travel at all.